Alright, so today we're going to be talking about the somatic and autonomic nervous systems. And we've talked a lot so far about what's going on inside of the head, what's going on inside the cranium, the lobes, their functions, right? The blood supply, what happens whenever that blood supply is interrupted, what happens when we have tumors in certain lobes, right? How to diagnose that stuff. But it's all been kind of inside the head. So we don't live in this brain in a vat sort of world, at least not yet. And so we have to understand how we're getting from the brain down to the hand, right? And from the hand back to the brain. Right? So how is it that as you're holding your pencil right now, you feel the grip? And how is it that as you're making the stroke with the pencil across your page, how do you do that? Right? How do you engage all these tiny little hand muscles? Right? And even more curious, right? How do you engage your gut, right? Without even thinking about it. How does your GI tract move stuff from your stomach down through your intestines, right? And from your large intestine or from your small intestine to your large intestine. How does that happen? Right? That happens underneath neuronal or nervous system control. And so we're going to talk about how do we get from the brain down to there and vice versa, how we get back. And these are going to happen through all these tracks. And so broadly, we're going to break this down into the somatic. And again, we've talked about this a little bit, but that's going to be things like conscious control and movement and conscious sensation, what you're actually feeling right now and what you're aware of. And we also have the autonomic system. There's going to be the things running in the background. That is going to be stuff like the gut, things that we don't have to think about. And that's good because you're already stressed out enough. Imagine trying to think about getting that food from your stomach into your intestines, right? Just one more thing to worry about. We don't have to. It kind of runs in the background. And then, again, this autonomic, we can break down into two categories. We'll use this as our general outline, but remember we have the sympathetic and the parasympathetic. The sympathetic and the parasympathetic. Remember, sympathetic is going to be something like fight or flight, right? What's going to happen whenever you're being chased by a tiger, right? The parasympathetic, on the other hand, is going to be our feed and breed, or the rest and digest. What's going to happen whenever you're sitting around the campfire at the end of the day, eating your meal of what you hunted during the day, right? So they seem to have kind of opposing effects, and we'll talk about why that is and how they go about doing that. And then the somatic nervous system, we can break down into, again, kind of two categories, and we have our motor, our somatomotor, and sensory or somatosensory pathways, right? And then we can break these down into even more, as we'll see, right? So motor, right? We have a few different divisions, like the pyramidal and extrapyramidal tracts. We'll look at those. All right, sensory, same idea. We have something like the dorsal column pathway and the anterolateral spinothalamic. And we can kind of break those down more, and we will. But again, this is just kind of our broad overview of the somatic and autonomic nervous system. And so we'll start here at this story of the cranial nerves. So what exactly are these guys doing? It seems like a lot, but we don't have to worry about all of these at the moment, but we need to have kind of a rough understanding. And we have two that come from the actual cerebral cortex, right, and the rest are going to come from the midbrain and the brainstem. Mostly the brainstem here. We can see a lot coming here out of the pons, right? A lot here out of the medulla, right? Then a few here at kind of the proximal part of the spinal cord, right? And these are all going to be peripheral nerves. Right? So even though they are coming out of the central nervous system, right, just like we have our spinal nerves that we talk about that will come out of the spinal cord, right, these are still all going to be peripheral nervous system. And that means they come from what? They come from neural crest cells, right? So let's remember the peripheral nervous system derives from these neural crest cells. And they go on to make a few other structures, if you remember, things like the chromaffin cells in the adrenal medulla. Again, something we'll come back to today, right? And melanocytes in the skin. Those neural crest cells go on to produce several structures, not just the peripheral nervous system. And you can scroll down here and see what each one of these does. And a lot of them are kind of contained here in the head. You see like the trigeminal nerve right here, and controls a lot of the face, along with the facial muscle, or the facial nerve too. And that's why you can have somebody like a quadriplegic, somebody who's paralyzed from the neck down, right, still able to talk, to speak, to blink, to look around, probably even move their neck, because we have this accessory or spinal accessory nerve, right, may let us turn and shrug our shoulders a little bit, right, even though we're paralyzed from the neck down, because you can see if we have a problem there, everything up here is just fine. It's still getting out, right? But there are a couple that we do want to worry about here, right? The first one is going to be what's probably one of the most important cranial nerves. That's going to be the vagus, or cranial nerve 10. Right? So we'll see this shorthanded a lot as cranial nerve 10, or you can just say vagus, either one is fine. And it's really important because we can see how far it goes, right? It actually means the wandering nerve. It goes everywhere from your ears to your bronchi, the lungs, right, heart, GI tract, right? It goes everywhere. And it's going to wind up being one of those autonomic nerves, and we'll talk about that in just a second. Right? The other one that's extremely important is this glossopharyngeal nerve. Right? Both of these are going to play a role in one of our most important autonomic reflexes, which we'll get to. Right? But the rest, we don't have to spend a lot of time memorizing the rest, at least not for now. Right? But focus on these two for the moment. Right? Let's go ahead and get a rough idea of the spinal cord anatomy. Where do these sympathetic and parasympathetic nerve roots start? Where do these somatic nerve roots start? Right? What's going on here? How do we get, again, from the brain? So our idea, we want to know how we get from the brain here, right, out to something out here. Right? And it's going to happen, at least to the somatic tract. General idea is we're coming down, so imagine this is motor, and we come out of one of these nerve roots here. And we're going to connect to it that way. And we have these specific nerve roots coming out. And they're going to come out in specific regions of the spinal cord. And those regions are going to be cervical, thoracic, lumbar, sacral, and then a coccygeal region. And we have a very specific number of nerves that come out of each one. So you see we have 8 cervical nerves, 12 thoracic nerves, 5 lumbar and 5 sacral, and then we really have just one little coccygeal nerve here at the bottom. And some of you guys may know the mnemonic. If you actually eat your meals during this time of day, right, some of you may know this as when you're supposed to eat. You have breakfast at 8, lunch at 12, dinner at 5. I don't eat my meals at any of those times, but if it helps you remember. But either way, just come up with some sort of device that we have 8 cervical, 12 thoracic, 5 lumbar, and 5 sacral. And then, one little coccygeal at the bottom. And we're going to respectively call these by where they come out and their sequential numbers. So this first one here is going to be my cervical nerve root 1, so we just call it C1. The second one there is going to be C2. We do this all the way down and we have C8. We can count that, right? C2, 3, 4, 5, 6, 7, and 8. And then same idea here. So we're going to have T1 through T12, L1 through L5, and so on and so forth. That's going to be important because each one of these is going to come out and correspond to a very specific area of the body. And we'll look at that in just a second. But for now, let's take a look at what's going on in each one of these. So let's take a look at our autonomic system first and see where the autonomic system is going to originate. And remember we said we have these little cranial nerves coming out of the brainstem, right out of the pons and the medulla, and it'll come out like that off to the side and go to their various locations. And what's important to remember about this, again, even the ones that run throughout the body, like the vagus, so we'll just call this one our vagus, right? That's not going to run through the spinal column, right? It's not going to be inside of the vertebrae. It's going to run exterior, through the body, looking something like that, and it'll have various branches. But it's important to note that we can have an injury here, some sort of spinal injury, and this over here is just fine. Right? Again, this is how you can be paralyzed from, let's say the shoulder down if you have something right there, but all of your GI function is still working just fine, right? Because this cranial nerve, this vagus nerve, hasn't been affected, and it runs outside of the spinal cord. We can probably get an idea of there's a pretty good evolutionary advantage for that. Right, but let's look again where each one of these comes out. Remember I said that vagus nerve is part of, it's a really big autonomic nerve, and specifically it's particularly important in the parasympathetic system. And so we actually see that all of our parasympathetic nerves are going to come out of the brainstem right there. Right, so parasympathetic from there, and then from one other area, from the sacral region. And so from the sacral area is also going to be where the parasympathetic nerve roots come from. All of them. Right? We don't have any parasympathetic nerve roots coming from the cervical or the thoracic region. Everything involved in your feed or breathe or rest and digest nervous system originates and comes out of these two areas. And then the sympathetic, on the other hand, we'll go red because, danger, run. Right, so the sympathetic, on the other hand, is all going to come out of the thoracic region. So all of your fight or flight nerve roots, right, the things that initiate fight or flight response, all of those nerve roots are coming out of the thoracic region. And what's really cool is there's actually, if you crack open the sternum and look alongside, just lateral to the spinal cord, you'll see what looks like almost like another little mini spinal cord attached to the ribs, just beside it. You'll see all these little ganglia, or all these little cell bodies where they're synapsing. And this is what we call the sympathetic chain. It's a sympathetic chain. Right? And what's really cool about this is it's actually where, so we can imagine we have a sympathetic nerve coming out of, what would this be? So T1, T2. So imagine the sympathetic nerve root coming out at T2. And it's actually going to link up at that ganglion right there. And then another sympathetic nerve coming out of that ganglia. And this is what you may have heard called a pre- and post-ganglionic sympathetic nerves, right? So we have a preganglionic sympathetic nerve, or neuron, and a postganglionic sympathetic neuron. We'll look at those in just a second because they behave just a little bit differently. But this is cool because each one of these is also connected to each other. All these little ganglia, right, and this is why it's a chain, are connected to each other. And this allows for a quick dispersal of this sympathetic activity. This is why sometimes you ever have a car pull out in front of you, and before you know it, your heart rate is elevated. And before you know it, you're breathing heavily, right? Your pupils are dilated, right? You start sweating. That's because whenever you realize that up here, right, and it's traveling down here, right, we can also have this little backup chain that fires this incredibly rapidly, right, before you even really process what's going on. Right? Same idea as whenever you step on something painful or somebody hits you with something, your sympathetic system will actually be activated before you even process what's going on up here, right? So some painful stimuli comes in this side, right? You'll have these little reflex arcs. We'll talk about that in just a little while. You can actually have this sympathetic activity activated really quickly, right? And that's good because we need to be prepared to respond to whatever this painful stimuli is over here. Right? But we'll come back to that in just a second. So for now, let's make sure we understand where each one of these comes out. So parasympathetic is going to originate from the brainstem, the sacral region. Sympathetic will come out of the thoracic region here. Right? And then our somatic system is going to come out of each one of these. We'll put somatic in blue. Right? Is going to come out of our spinal roots here, our nerve roots at every level. All right, so remember we have motor going out, sensory coming back in. That's happening at every level. And these correspond with very specific body regions. Right? And we're going to call those dermatomes. And if you scroll down, we see where each one of these comes out. And we actually have a map here of each one of these dermatomes. We'll come back to that in just a second, but just kind of an idea of where we're heading. Now, if we take this spinal cord and we cut it, we cross-section it through any one of these, right? We just take a cross-section and flip it over. We're going to see something like this. So we can imagine something like that. We got our central canal in the middle. Remember, CSF runs through there. Around the edge, we have our meninges. Our CSF is surrounding in here. And inside of, you can kind of see this, looks like a butterfly, right? Inside the butterfly is going to be gray matter. Right? And outside is going to be white matter. So what's gray matter? Gray matter, remember, is where all of these cell bodies or the dendrites, right, and the boutons are going to be synapsing. Right? It's where we have unmyelinated parts of the axon. The white is where we're going to have myelinated parts of, unmyelinated parts of the neuron in here. And outside is where we have the myelinated part of the neuron or the axon. All right? This is important to remember because this butterfly is where these nerves or these neurons are actually going to come in and synapse and go other places. And so let's label this a little more. This is going to be the ventral side or anterior. And this will be the dorsal side or posterior. All right, and then we'll just kind of arbitrarily say we have a left and a right. And so if we draw the vertebrae around this, and we can imagine the posterior side is going to be where the spinous process is going to be, right? And you can feel that if you lean forward in your seat and rub your hand along your back. You can feel where those are poking out. It's your spinous process. It's the back of the posterior side. Right? And then in front of that, we have our big vertebral bodies here, right? Where the big intervertebral disc will be. Right? And that's going to be anterior. Then your guts, right? All your internal organs will be somewhere, up there. Right? Get rid of all that really quick. Get it out of the way. Right? And we can, very broadly speaking, break this into the two sides we talked about, the ventral and dorsal, right? So this is going to be dorsal horns here and ventral horns here. And the dorsal side is going to be, again, very broadly speaking, where our sensory neurons are going to come in and out. Right? And then conversely, again, we're talking about the somatic system here. On the ventral side, it's going to be where the motor neurons come in and out. All right, so that means that all of our sensations are going to come in to the dorsal horn here. They'll come in that way. And then depending on the track, they'll go various places. And all of our motor pathways, for the most part, again, this is a generalization, but most of our motor pathways will come out of the ventral side there. And just kind of a good basic understanding. Now, before we move on, I want to draw your attention to a few other things on here that we should probably note. So erase all that for you guys. So, if you look over here, we have these things called plexuses. And we have 3 to 4, depending on how your textbook breaks them down, but we have a cervical, which will be the neck region, brachial, which will be arms, a lumbar, and a sacral. And I say 3 to 4 because some textbooks link these up into a lumbosacral plexus. All right, and what's going on here in these plexuses? What is a plexus? And if we zoom in here, we can see and get a rough idea of what's going on. So imagine you have some sort of really important target organ out here. All right, we'll say these are the lungs. Right, and we have the phrenic nerve that feeds the lungs. And so the phrenic nerve, let's just say, if it only came out of C4. So we have C1, 2, 3, 4. So let's say we decide we want to breathe. It's a good thing to do. We come down, out C4, and innervate the lungs via the phrenic nerve. All's good. But now you can imagine if something happens and we injure the spinal cord or the nerve root right there. Now what happens? Well, this signal's blocked. Right? It can't get through. It goes down and it's stopped right there, and so the signal doesn't make it to the lungs. Well, that means death if that's the only nerve that's going there. Right? We're done. So what's happened here, and what these plexuses do, is now, if we follow C3 along, we can see it hooks up right there. Right? And also supplies that. And so we're actually good. We still get a signal there. We're okay. Had it been just this C4, we would have been done. But we have this C3, and actually, we also have C2 coming down and linking up, right? All these kind of cross-talking, right? And you can imagine these plexuses is a form of crosstalk. Right? And what they give us is a backup plan. They give us a fail-safe. And this is going to be really important. You can see why this would be evolutionarily advantageous. And look at where they're at. Why do we have them in the cervical, the brachial, the lumbosacral region? What would be the evolutionary advantage of those? So I want you to kind of think about that as we move forward through here. Why those regions? All right. Let's move on to these dermatomes that we've talked about. I'll write this out here. All right, dermatome. What do we mean by a dermatome? So we're talking about specific areas of the skin, right, the derm, or the body, that correspond to each one of these nerve roots. All right, so that just means that the nerve coming out of C1 corresponds to a very specific area that we can narrow down and say this is the C1 area of the body. And that's true of any one of these. Whether it's T3, right, we know what the T3 area of the body is. We actually haven't mapped out. That's what we see here. It's called a dermatome map. And if we look closely and draw your attention down here, we can see that. So C6 is going to be the thumb, right? And then we move medially. C7 would be the pointer and the middle finger. Right? C8 will be the pinky and the ring finger. And that really means that from C6, we can imagine if our C6 spinal root comes out of there, it's actually running all the way down the arm to the thumb there. Right, and this moves two directions. Right? This also corresponds to your sensations from your thumb move all the way back up into C6, right, into that dorsal horn that we talked about. Moving that direction, right, and this one's going to be moving this direction, but they all come from the C6 there, and this is true for any one of these. Right? And this is really useful whenever we're in the clinic, because we can actually figure out where in the spine, without doing anything invasive, we can conclude where in the spine the lesion might be. And we'll do this in just a second. Right. Sorry, get things out of the way there. Now, it's a little overwhelming whenever you're first learning these to just kind of try to memorize every single one of them. And I would discourage you from doing that. So how are we going to learn these? So let's pick some landmarks that we're going to identify. All right, so we can know that C6 through C8, right, are going to be, it's going to be our hands. All right, so, and we know it's going to move from lateral to medial like that. Then we pick other landmarks and we can just kind of fill in the blanks from there. So one of the easiest ones is right here at T4, right, what I'd like to call the nipple dermatome. All right, so T4 is going to be right there along the nipples. T10 is going to be right here at the navel or the belly button, right? And we can fill in the blanks from there. Right? And a few others that we should probably note, right? The S2 is going to be the genitals for male and female, right? Our L1 through L5 is going to be the anterior part of the legs here, right? And then the rest from there, S3, right, through S5 are going to be the posterior, right, part of the legs here. It's going to be S3 through S5. And so we pick a few landmarks like that, and it's really not too hard to fill in the blanks in there. So your patient is having issues at, somewhere in there. And it's below T4 and above T10, so we can take an educated guess based on which one it's closer to, and let's say, maybe that's T8. And we look and, it's T7, but it's not too far off, right? We can get pretty close. But there are a few big ones like that, like the S2, the C6 through 8 that we should learn. And this does us a lot of good clinically. So let's imagine a clinical case. You have a patient that comes in, and they say that they've been having numbness and tingling and difficulty moving. Well, actually, let's just say, they're having difficulty moving their pinky, right, their ring finger, their pointer, and their index finger. So let's say all of their, 3 jointed fingers, they're having trouble moving. Well, you, being the astute physician, you ask them, well, what about your thumb? How's that? And he says, no, I have absolutely no problem moving my thumb. So that gives you a lot of information just based off of that quick analysis. So we look at our dermatome map, and we'd say, okay, so thumb is okay, but you're having issues here in C7 and C8, those fingers. We know that by knowing the dermatomes. And you start to ask, what about movement below that point? And he says, well, actually, now that you mention it, I've been feeling general weakness, kind of from my upper chest down. Right? And this tells us a lot. So we come back up here. I'm going to find out if it is indeed a spinal injury. What's going on? So we just said our C7 and C8 aren't working so good. Then we realize everything below isn't working so good. But C6 is just fine. He actually says, I can shrug my shoulders just fine. Everything above that feels just fine. So all of that is okay. right? And this kind of gives us a general principle of these spinal tracts, and that is their directionality and what happens at these injuries. So based on this, we can probably say, let's give it a color that we'll be able to see, the injury is going to be here at C7. So our motor neurons coming from the somatomotor cortex are going to come down, right, moving that direction, and they're moving along just fine. And they come out of here, nothing in the way. But we get to this injury, and now we can't get a signal through there, right? You can imagine if you're driving down a road and there's been an accident, what happens? Traffic backs up. You can't go anywhere if the road is blocked. And the same is true of these signals. If the road is blocked to the spinal cord, we can't go anywhere, right? So all that signal getting below the injury is affected, and that'd be the movement. So what about the sensation? Right, so coming in above the injury, we're going that direction. Right, all of that seems to be just fine. There's nothing in the way. But now we get below the injury. Again, we go up, and then we're blocked right there. Right, we can't actually get that sensation from T4 up to the brain. Right, there's been something in the way. It blocks it. And so it's kind of like a one-way street that you're stuck on. And a few of these, again, have these little side routes. That's why we have the plexuses to kind of divert that. But if there's not something like a plexus, then we're done. Right? There's no way to get up. And as we look at more spinal cases, that'll be important to note. So these dermatomes are really important for diagnosing these clinical cases. All right, so here you can see these are this is a subluxation chart, and this is kind of the guiding principle if you look at things like chiropractic therapy or osteopathic manipulation therapy. Right? The idea is if any of these vertebrae are out of line, they put pressure on these nerves coming out. What we just talked about is kind of a one-way street. If you can't, if we have pressure right there, then we're now affecting the downstream signal, right, to all of those structures. And so we have problems. So this chart just kind of shows you the general problems that we can have whenever we have subluxed vertebrae. Not something you have to memorize, but this is really good to know because if you understand it, then it shows that you're starting to form an understanding of these different dermatomes and that you get that C1 supplies these certain structures and so on and so forth. All right, now, before we move on, one more important thing to note about this spinal anatomy. Right? We see this kind of strange event where, let's look at the spinal cord, and it almost looks like it ends right there. And then from there, you have all these little nerve roots coming off like that. Right? And they'll still come out like that at these different levels, but they come down. And this is because your spinal cord, like the actual cylindrical shaped cord, ends somewhere here around L2. Right? The actual physical bulk that is held together tightly ends at L2. And that point, you see it comes down into almost this cone shape. We call that the conus medullaris. I will write that down here. The conus medullaris. Right, and then we have this structure of all these nerve fibers, still kind of tightly bundled, but a lot looser. Right? And it looks almost like a horse's tail coming out. That's exactly what we call it. This is what we call the cauda, right? Tail in Latin, equina. Right? Horse. It's the horse's tail. And then it all comes down into this final little point right here. That's going to be called our phylum terminale. Phylum terminale. All right, and that's actually where the meningeal layer is going to come to an end. Right, so all this is still kind of loosely held within this meningeal layer. Right, and remember, what's inside of this meningeal layer? Right, so we'll just imagine the meningeal layer still encasing all of this. Right, and remember, we have CSF inside of there. And so it brings me to another question. Why would it be better whenever you get a spinal tap and we're trying to extract CSF, why do we not go in to the thoracic region with our needle? Right? We call them a lumbar puncture. Right? We actually go into the lumbar area here. Why do we do that? Why would it be better to go into the lumbar region than it is to the thoracic region? Right, so just one more thing to think about. And then one more thing to note, this phylum terminale here, right, shouldn't actually be attached to this bottom part of the coccygeal region. Right? It should be kind of free hanging. And whenever we are born, or sorry, not whenever we're born, but whenever we're developing, right, and as this is elongating, well, actually it will attach down here. Right? So that way it reaches its end, and as your spinal cord's elongating, it has an anchor point. But at some point that should free itself. This doesn't always happen, and if it doesn't happen, it results in something that we call tethered cord syndrome. Right, so tethered cord syndrome. All right, something to look up that you should know. It's going to produce lots of weird symptoms. So won't go over it here, but make sure you take a look at that. All right, so now we have an understanding of our basic spinal cord anatomy, where these somatic and autonomic nerve roots are going to come in and out and what they do. All right, so let's jump down here and kind of make sure that we get everything. So remember our vertebral body here. This is going to be the anterior or the ventral side. Right, so we're going to call it ventral. And then the posterior, right, or dorsal side. You can see we have our spinous process coming off the dorsal end, and then this vertebral body off the anterior or the ventral end. And that's important to get when we're looking at MRIs of this stuff. And then see the spinal cord is going to run here through this vertebra foramen, right? And then we've seen the rest. All right. One thing to note is we have two pretty unique vertebrae here. Our C1, so our cervical vertebrae 1 and our cervical vertebrae 2, the atlas and the axis. And we can get this, the atlas, right, C1 is the one that the head sits on. So you can think of the atlas, right, is what? It's like a globe. So it's the atlas is the one that the globe sits on. Right? And the axis, so what is an axis for? It's something that you rotate around. So the axis is what allows the globe to rotate. You look to your left, you look to your right. It's what allows us to do that. That's through this little thing right here called the dens, or you may see it as the odontoid process. Sits nicely right here so that this can rotate either way. All right, the rest of our spinal cords lock neatly together. There's not much rotation allowed, but here we kind of have this free rotation either way so we can turn our head. All right, and remember we looked at, again, we have ventral, anterior, right, dorsal, posterior. We looked at this. We have the gray matter, white matter, right, and then sensory coming in through the dorsal root ganglia. Right, it goes through there, and then our motor coming out of the ventral horn there. All right, so here, don't get bogged down too much in the names of all these arteries and veins. They don't matter to us too much at this level, but what we do want to note here is that this definitely is still central nervous system tissue. And just like our brain, right, we got to get blood to it. Right? These neurons have to have supplies. So they come in various places. And just like the brain too, we can have clots that come in here. And remember, just like we have clots in coronary arteries, then we have myocardial infarctions or heart attacks. We have clots in cerebral arteries. We have strokes or cerebral vascular accidents. And we can also have those strokes here in the spinal cord. So imagine we have a clot coming in and it gets stopped up right there. So now all of this becomes ischemic. And we should know the sequelae of events from there. We have ischemia to hypoxia, right? We have the disruption of the electron transport chain, right? So no ATP, no sodium-potassium pumps. And then we have cellular dysfunction, right? No regulation. And eventually we have infarct. Right? We have tissue death. And what's that going to show up as on our MRI? Well, it'll show up pretty similarly. We're going to have all that dark right there on the MRI. And based on where it is, we'll have symptoms at that location. So, and if this is actually let's stick with something that we're already familiar with. If this is at C6, right, we're going to have problems in our thumb and below. Because remember, all these tracts trying to get through here, they're coming down. They can't get through there. They're blocked. So whatever symptoms we have will be in C6 and below like that. Same idea. Those coming back up. They can't get through there. They're blocked. So can't go through. All right. So that's really all we need to know about that. Again, our meningeal layers in the same order. Right? The dura, arachnoid, pia from superficial to deep are going to still surround the spinal cord. And we should know some of the larger ones. Again, something we're familiar with. We see these vertebral arteries coming up, and they join together into the basilar. The internal carotid comes off. So this is our carotid arch, this is our aortic arch. So common carotid comes off, it breaks up into external and internal. It looks something like that, up to the brain. So we already have a rough idea of how this goes. And see, we have all these little accessory arteries running and feeding the spinal cord here. Again, just more of what we've talked about. So we can take a look at this, but this just really outlines all the stuff that we've seen already. And we see how some of these nerves join up and crosstalk. So now let's get to the ascending versus descending tracks. And a couple things that we definitely want to make note of is a few guiding principles of what distinguishes these. Other than ascending, right, is going up the spinal cord, right, and descending is going to be coming down. So ascending then is going to be sensory. Right, and they're what we're going to call afferents. Right, afferent with an A. Sensory afferent. Descending, coming down for the brain to the muscles, then it's going to make it motor. Right? And it's causing an effect. Right? It is our efferent. We have our motor efferents, or our descending tracts. Right? And a couple things that will help us out is if we always remember these ascending tracts will always take 3 neurons. That's all it takes to get from touching, right, to perception. Right? I shouldn't say perception, right, because there's some integration, but that's all it takes, 3 neurons to get from touching to the somatosensory cortex. The motor, or our efferents, on the other hand, Remember, so we're talking about somatic motor, will take only 2 neurons. Right, to get from the somatomotor cortex to whatever our effector organ, like our muscle. That's all it takes. And they're going to follow, all of our tracks will follow kind of this similar pattern. And so the general outline of these ascending tracks will be these 3 neurons. Again, we're going to talk about a couple different tracks, but they're going to follow the same guiding principle. So we have this, let's change colors here. Let's go with orange. All right, so we have this first one. We're going to call that one our first order afferent neuron. All right, first order afferent neuron. Then it's going to come in and it's going to synapse with another neuron. All right, so depending on which track we're talking about, it depends on where that second one is going to be located. But in general, we'll just follow this one. But in general, it will come in and we're going to synapse somewhere within the central nervous system. I'll do this in a different color. With our second order afferent neuron. And it's going to go up, and then at some point it will synapse with, you guessed it, the what we call third order. Well, that one's a little hard to see. Our third order afferent neuron. All right, and that's where, the general pattern that each one of these is going to follow. With the ascending, we have a first order, second order, and third order afferent neuron. Right? First order is always going to begin at the point of stimulus, at the point of some sort of sensory receptor. Right? That's going to be attached to. Right? And then it's going to go and link up somewhere within the central nervous system with the second order afferent neuron. And that one will go on to link up with another central nervous system neuron, our third order afferent. All right, and depending on which track we're talking about, that occurs in different places. The motor, on the other hand, will follow the same principle. Now we'll keep our first orders in orange here. So our motor, we have this one coming out, originating in the somatomotor cortex. Right, and it's what we call, again, our first order efferent, our first order motor. Right, efferent's important though. Our first order efferent neuron. And then it hooks up to one of these peripheral motor neurons. Right, and it's going to be our second order efferent neuron. All right, and again, it's important to note this is peripheral here, and our first order is going to be central. And we can also give these another designation. Let's call this an upper motor neuron. And if we have an upper, we must have a lower motor neuron. And the upper and lower motor neurons, respectively, again, will be central and peripheral nervous system. And depending on where the lesion is, again, we'll talk about this where we get to spinal lesions, it's going to give us very different symptoms. All right, so there's our general overview of ascending versus descending tracks. 3 versus 2 neurons, and then the direction that they're going. All right, this is something that, again, don't freak out. This is a medical school level outline, but we can notice some important things that we've already talked about. Remember, we talked about anterior, or the ventral side, are going to be our motor neurons coming out of there. And then the same thing, the dorsal root, right, are going to have these dorsal these sensory neurons coming in. All right, and the rest are going to be all these other tracks that we're not going to worry about right now. Things like, we are going to talk about the spinothalamic tract, but we don't have to know all these little subdivisions. All right, and then things like our tecto, reticulo, vestibulo, right, all of our little extrapyramidal tracts, which we'll get to. All right, so now we're on to sensory systems. So let's outline this in detail. So again, remember how we talked about, we don't even have to go through this slide now because we already talked about it. And peripherally, we have first order, then inside the central, we have second and third order. And that's just the general outline. And then again, depending on which track, these areas here will change. But one thing to note, actually a general rule that we can hang on to, this third order neuron is actually going to begin and end in the same place for both the tracks we're going to discuss. So if you want to go to make note of this third order neuron will always begin in the thalamus and it will always end in the somatosensory cortex. All right, and this brings us to our two different tracks. So we have I'll highlight the names really quick. We have our dorsal column pathway, and then we have our spinothalamic, or the anterolateral spinothalamic. Right? This one, our first one, our dorsal column, is going to be, we'll call this the touch pathway. Right? This is going to be things like fine touch, feeling your pen, right? Things like light pressure, fine touch, things like that. This is going to be this dorsal column pathway. The spinothalamic pathway is going to be our pain pathway. So your pencil slips out of your hand and the lead kind of stabs into your fingertip. That's going to activate this spinothalamic pathway. That pain's felt through these three neurons in the spinothalamic tract. Right? And then it's also responsible for things like painful temperature too. Right? So we can put temperature. Right, painful temperature. So whether it's been so cold this week, you walk outside, right, your fingers hurt. Again, that's that spinothalamic tract at work. And so let's look at where each of these begins and ends. So the dorsal column pathway, we'll outline this one in blue. Right, nice feelings. All right, it's going to come in, again, like we said, these are both going to come into this these dorsal columns, these dorsal horns. All right, so it's going to come into the dorsal horn. But now notice there's no synapse there. And so we erase all that just to get a clear look. There's no synapse. It keeps going. And this little, we'll come back to like this little guy here in a second. But it's not going to actually synapse with anything right there in the spinal cord. Instead, it's just going to go up. So it enters the dorsal column and it goes up. And where does it go? Well, it goes up to the medulla. And so in the medulla is where our first order ends. So the first order neuron begins here at our receptors. All right, we have the mechanoreceptors, which are going to feel physical force, proprioreceptors, which sense stretch. All right, so this first order begins there at that receptor and ends in the medulla. Right? And then in the medulla, the second order neuron starts. Right? So the second order is also going to cross over here in the medulla. Right? So we've talked about before how the left side of the brain controls the right side of the body, so that it has to cross over somewhere. Or, we feel right side of the body on the left side of the brain. And the second order neuron of the dorsal column pathway crosses over there. And then, remember we just said that third order neuron always begins in the thalamus and ends in the somatosensory cortex. So second order ends in the thalamus, which is where our third order begins. And that third order goes up to the somatosensory cortex. All right, and that's how we feel touch. All right, so how do we feel pain? Let's switch over to red, right? Pain, bad. Right? We'll go with red, it's intense color. All right, so same story. We have these nociceptors, or pain receptors, and it comes up, and it's going to enter in the same place, here in this dorsal column, or this dorsal horn. All right, so it enters there in the dorsal horn. But this is where the story kind of diverges, as instead of going straight up, our first order neuron is actually going to go ahead and synapse with a second order. So now my second order neuron begins in the dorsal column, or the dorsal horn, of the spinal cord. And is going to cross over, and this is why this is also called the anterolateral spinothalamic tract, because it's going to cross anteriorly and laterally into the ventral horn. All right, so it actually crosses over, the second order crosses over into the ventral horn of the spinal cord. And then from there it goes up. And again, different from that dorsal column because there are no stops here in the medulla. It goes straight through the medulla up to the thalamus. All right, and that's where it synapses with that third order. Right, that third order always begins in the thalamus, ends in the somatosensory cortex. All right, so let's go back over that. First order begins out here peripherally, the nociceptors, or those thermoreceptors, and enters into the dorsal horn, crosses over to the contralateral, right? Contra means other side, right? So contralateral ventral horn, and that second order then goes up to the thalamus. Right, so it ends in the thalamus. Then the third order is going to begin in the thalamus and end in the somatosensory. So now that tells us the difference here. So the difference that we want to worry about is, where does each nerve synapse in each pathway? Right, and where do they cross over? So spend some time with that and make sure we understand that, because this is going to be vital for diagnosing spinal injuries. As we move forward, imagine if we have a spinal injury on this side, right? Well, this pathway, and we'll draw this on both sides here. Right? This pathway, the touch pathway, is not affected, right? This keeps going through and it's up and it's fine. This pathway, however, we've now cut this axon and it stops there. It can't go anywhere. And this is where we get these really weird symptoms, like your patient could feel touch somewhere. You could take, a feather and rub it across their hand and they'll feel it, but then you take them and you do a pinprick test and they don't actually feel that. Right? So they can feel touch but not pain. And that's why we have to know these pathways, because that'll let us know where the lesion is inside the spinal cord. Not only, the vertical level based on the dermatome, but now we can even diagnose where inside the spinal cord, right, whether it's dorsal or ventral, right, in which horn. We can actually get as detailed as, the left dorsal horn or the left ventral horn, right? We can get down to that level of detail just based off of patient symptoms, and that's where we're going. So make sure you know these tracks very well. All right, and then here's just some more outline of that. We're not going to spend a lot more time on this. Just make sure that whichever one of these you feel most comfortable with, just looking at where these connections occur in the crossovers. All right, and here we kind of see the different kinds of endings. This one, that one's probably a Golgi body, right? So that's something like stretch receptors. Right here is what we call free nerve endings. This is how we feel pain. Right? We have, these little Merkel discs here and Pacinium corpuscles. Right? So this is going to give us light touch, deep pressure. And these, you might also hear these as Meissner's corpuscles right here. Right? And then again, these free nerve endings, or how we feel pain. Right? And then you can see that'll just go up and follow that same pathway. And it's pretty cool because, again, it's true. It's really just 3 neurons to get up there. So you feel the pain right here at your fingertip, and there's just one neuron, well, not just one, because you're probably going to trigger a bunch of them, but you can trigger just one neuron. That one neuron will go all the way up your arm and won't stop until it synapses with that second order neuron in the spinal cord. That's pretty cool. All right. But now we have, draw your attention to this pain, what we call pain attenuation. All right, so draw that out, write that out. So pain attenuation. This just means we can kind of help out ourselves. We can help ourselves when we're in intense pain. All right, and so the first one, so we're going to talk about 2 different ones. We're going to talk about a local pain attenuation, and we're going to talk about a spinal pain attenuation. All right, and so let's run through this local one really quick. And for that, we're going to have good old Peter Griffin here kind of, oh no, where'd all of my stuff go? Well, let's see if it pulls up in my, nope. All right, well, there's got to be history here somewhere, right? There we go. All right, so, don't judge my YouTube history, but we can see here, watch Peter from Family Guy come and trip and fall, and what's he do? The same thing we always do whenever we all trip and fall and skin our knee and we grab it, right? Why is our first instinct to grab whatever is in pain, right? You get a paper cut, what do? You start squeezing the finger, and it makes it feel better, right? You skin your knee, you squeeze it, and it makes it feel better. Why is that? Right? And that's what we call our local pain attenuation. And so here we have the skint knee, and it activates this pain receptor. So again, this is our first order afferent neuron of the spinothalamic tract coming in. Again, where's it going to come in? It's going to come into the dorsal horn. Right? And it should trigger this second order afferent neuron of the spinothalamic tract. Right, it's going to go up to the thalamus, and we know the story from there. But we can actually have this little inhibitory interneuron. And sorry, this is actually showing the spinal pain attenuation. So let's run down here really quick. Right, so here's our local one. And here's what happens. So again, pain coming in here, our first order afferent neuron, and it should go on to trigger this second order afferent neuron of the spinothalamic tract. And it's going to go on and do its thing, and it's going to go up to the thalamus and then to the somatosensory cortex, and we know the story. But what we can also do in this situation is we have these other neurons coming in of the dorsal column pathway. And so we can actually, we can think whether we touch our hand or we squeeze it, that we're activating this other pathway, just this touch pathway. And, it does its thing. We still feel the touch. And it goes up into the dorsal column and then just, straight up to the medulla. But it also has this other little branch here. Right? Remember I said we'd come back to that whenever we were looking at this drawing right here. We said, it goes up and it does its thing there, but there's this other little branch here. Well, that's what we're coming back to. So this other little branch is going to activate an inhibitory interneuron. So, right, an interneuron, just something in between. And so this interneuron is actually going to secrete these inhibitory neurotransmitters. Right? Most commonly, this is going to be GABA. Right? Our inhibitory neurotransmitter. And so what are we doing? We're trying to inhibit this second order afferent neuron of the pain pathway. Because if we can inhibit that, we silence it, and now we don't feel as much pain. Right? We weaken the signal. Right? We try to stop the action potential from propagating so we don't signal upstream. And so now this one's still secreting. So the first order, it's still feeling pain. It's still secreting. It's painful. We'll switch that to red. All right? Our pain neurotransmitters to try to activate this, but it's being competitively inhibited by the GABA molecules of this inhibitory interneuron. Right? And that only happens whenever we activate it through squeezing, that site that we're in pain. So we activate it, we squeeze, and then we signal that inhibitory interneuron. Right? Without it, this inhibitory interneuron doesn't do anything. It's not activated. It doesn't actually secrete. It's GABA. So we're free to feel pain. Right? We squeeze it, and now we block the action of these, and we never trigger our second order afferent neuron, which is pretty cool, right? And so this has a few evolutionary advantages. So one, we don't like to feel pain, but why don't we want to? Why do we want to squeeze? And this is kind of be summed up into some sort of advantage in survival. So we squeeze it. And what's the first thing you do whenever you start bleeding? If you're trying to stop bleeding? Well, you put pressure. Why? Because you're trying to coagulate the blood. So there's one explanation. We're trying to, stimulate coagulation and clotting, right? We're also trying to get the blood to pool. It helps wash the wound, right? So it helps do several things, but we also don't get to feel the pain, which is pretty cool. All right. Then we also have, again, this spinal signal. So, we hear about things like runner's high. So what happens with these spinal signals? Well, whenever the body senses that it's in stress, right, the midbrain here is going to activate, right, these other little nerves that are going to run down, and they're basically going to do the same thing at that level. Right? So again, the spinal one is going to be all within the central nervous system. Right, so this one is the PNS, right? So it's the dorsal column pathway helping to block this by stimulation of the PNS, right, of those peripheral nerves. This is all over here, completely within the central nervous system. Right? So we activate those, and we look here, and we still have that inhibitory interneuron right there. And it's going to do the same thing. It's going to release these neurotransmitters to help block that. But again, this time, and it doesn't just happen here, we can also release those, this isn't showing, is back into the brain. Right? And we release those neurotransmitters that keep it quiet. Right? But here in the central nervous system, right, it's going to be what we're going to release things like enkephalins. Right, enkephalins, and then what we all know, the famous endorphins. Right, enkephalins and endorphins. And these are just endogenous opiates within our own system. Right? We make our own opiates and release these to quiet down these other pain neurons. And this can happen down here at the level within the spinal cord. Right? It's the same thing. You can get a injection here at the level of the spinal cord to mimic this. Right? This is what something like an epidural during pregnancy or during birth. Right? That's what it's going to do. It's going to block it here at the level of the spinal cord. Right? Or we can also have it up here in the brain, and we have certain opioid pathways up here in the brain, right, that will just kind of block our sensation of it up here, right? So actually, we'll talk about this in a second. It's interesting, we don't actually know here in these higher levels where exactly it's blocking. We know it binds opioid receptors, but we don't quite know where, but we know that it doesn't make any noise, right? No pain stimulation above the thalamus. And that's how general anesthetics work too. All right, so now we kind of have a good understanding of the local gate control theory of pain versus kind of our spinal uh, control of pain, and then in the central nervous system. All right. What are some of the things we should probably make note of? Some of these things that cause pain. So we should note bradykinins and prostaglandins both cause pain. We have certain growth factors, right, that cause pain. And then things that come from within side of cells, right? So anytime you have lysing of cells, that's not good. So ATP shouldn't be floating around in your blood. If we have ATP extracellularly, right, it's actually going to activate those pain sensors because it tells us that tissue's probably been damaged. And same thing with these hydrogen ions. And then one really important, kind of the mother of all neurotransmitters, right? So again, these are kind of, strictly because of, damage to cells, but then these neurotransmitters coming out of the neurons, the big one is going to be substance P, right? So substance P is going to be our famous pain neurotransmitter. All right. And we can see different kinds of receptors. You don't need to know these for this class, but you will for med school. But we do have different kinds. Again, mechanoreceptors is going to be general touch, like mechanic forces. Right, these polymodal going to be for pain. Right, thermoreceptors. And yeah, that's how we feel. Here's a rough idea of the potencies of these painkillers. A lot of us have heard of fentanyl. Right, so these fentanyl cocktails in these opiate epidemics, it's fentanyl that's killing a lot of people because actual heroin is going to be somewhere along the level. It's going to be more than morphine, right? It's going to be somewhere on this level here. But whenever you have people addicted to these pain meds, here's the ones that you can normally kind of take home, then they need stronger and stronger stuff. And so a lot of times they turn to heroin, which is in this range, and then we have fentanyl, right? And fentanyl is making its way into recreation drug cocktails, and this is what's killing a lot of people, right? Because you can look at it, this is 80 to 100 times the strength of morphine, right? So this is as compared to morphine, right? So you have morphine here at a 1, right? 1 times the strength of morphine, right? So same thing. 80 to 100 times. So this is what's causing people to, overdose and decrease respiration rate to the point that they're actually dying. And then we have stuff that we commonly use here, things like ibuprofen, which is only 3% the potency of morphine, right? But it works pretty well for most purposes, right? It's a COX inhibitor, which is, you don't have to know, but it's an enzyme that converts arachidonic acid into prostaglandins. And remember we said these prostaglandins are pain. What's interesting is all of these, if you look, they all say precise mechanism not known. Precise mechanism not known. But we know they bind to opioid receptors. We just don't know exactly where or how. So, that's part of what makes this thing a real problem is we're still learning a lot about these drugs. Right, and so here's some of the inhaled anesthetics. A lot of you guys, right? So for general surgery, a lot of times we'll use fluoro a lot. Our original ones, right? So a lot of you guys may have had nitro or laughing gas for central or simple like dental procedures. Diethyl ether was the first surgical anesthetic, right? But it had a lot of problems. And so now we use kind of stuff up in, this range. Right? Propofol is the one that you guys will probably mostly know from surgical procedures. It's one of the largest for general anesthesia. But, we can use, a lot of these have become used for recreational. Again, things like ketamine, right? Diazepams, right, which we see as Valium, right, what House was addicted to. We're really familiar with all of these. So we have lorazepam, right, which is a benzodiazepine, right? It's our Xanax. So we use these a lot, and we don't really know how they work exactly. So, if you're interested in a good field of study, this is one to go into. All right, so now we covered our sensory system, and let's move into the autonomic nervous system. All right, so again, remember autonomic, we're breaking into parasympathetic and sympathetic. And then off to the side, we have the somatic. All right, and we've already talked about a lot of this stuff. So where it begins, so brain stems or the sacral spinal cord is going to be parasympathetic, right? The thoracic and lumbar spinal cords. And I don't know if I mentioned that earlier, but it's lumbar and thoracic for the sympathetic system, right? And both of these, so let's note some commonalities, are going to have two neurons coming out in the pathway. And remember we talked about we have that preganglionic and postganglionic, right? And then we're going to get into these neurotransmitters. So this is one of the most important charts you can know to make sense of the autonomic nervous system. You need to memorize and know this chart inside and out. So before we dive into it, let's get a few things down on this. So let's talk about the neurotransmitters that are used in the autonomic nervous system. And we're going to talk about their receptors. All right, so our two major neurotransmitters are going to be acetylcholine, right, and epinephrine / norepinephrine. Right, and the acetylcholine is going to go on to bind to, on our receptor side here, it's going to bind, let's make this blue, cholinergic receptors. Right? Choline for the acetylcholine, right? So it binds cholinergic receptors. Epinephrine and norepinephrine, right, also known as adrenaline, are going to bind, adrenaline will bind adrenergic receptors. Right? Adrenaline, adrenergic receptors. Right? And then these are going to fall into two different categories of each. Right? So for cholinergic, we have nicotinic and muscarinic receptors. Muscarinic. All right, so we're going to call them nicotinic cholinergic receptors or muscarinic cholinergic receptors. And we have several different kinds of adrenergic receptors, but we're going to worry about two in particular. All right, we're going to worry about alpha and beta adrenergic receptors. All right, so again, let's kind of go over this. Epinephrine and norepinephrine are going to bind to either adrenergic, alpha or beta adrenergic receptors. Acetylcholine will bind to either nicotinic and or muscarinic cholinergic receptors, depending on where they're at. I know it's a lot to take in, but let's see if we can make sense of this. All right, so the guiding principles are going to be knowing these neurotransmitters and their receptors, and then knowing the preganglionic and postganglionic neurons for each one. So this first one here, we can kind of ignore it for now, but that's just giving us an idea of the somatic motor neuron. We'll come back to that in just a second, but let's note here, let's start with the sympathetic system, which again, here in the thoracic and lumbar area. All right, so coming here out of the thoracic, come back to this one. Let's start here. We have our preganglionic neuron coming out and attaching here. It's going to synapse with the postganglionic neuron. And remember, we said this happens in that sympathetic ganglia. All right, so preganglionic is going to secrete, right, acetylcholine. Now, I know what you think. You're probably thinking, sympathetic, I always associated sympathetic with adrenaline or epinephrine. That's true, but not for the preganglionic. And while we're at that, let's go ahead and trace this parasympathetic coming here out of the sacral to its synapse right here. And it's also going to secrete acetylcholine. All right, so now we have a rule. All of our presynaptic neurons, whether they are sympathetic or parasympathetic, will always secrete acetylcholine. Right? And the postganglionic neuron will always have, I'll do this in green, will always have nicotinic receptors. Right? So again, postganglionic neurons will always have nicotinic cholinergic receptors for the sympathetic. Right? For the parasympathetic, also the same, nicotinic cholinergic receptors. All right, so now let's look at the postganglionic neuron for each one. So sympathetic. This postganglionic now goes to our target organ. Right? Goes to the target organ. And it's going to secrete, now we have our norepinephrine, because it's a neurotransmitter, it's coming from a neuron. Norepinephrine being secreted by the postganglionic sympathetic neuron. Right? And it's going to bind to either an alpha or a beta receptor, depending on where it's at, because sometimes we want different functions in different organs. Postganglionic parasympathetic neuron is going to go to its effector, and again, it's going to release acetylcholine again. All right, so our parasympathetic is acetylcholine from both the preganglionic and from the postganglionic. Right? Whereas the sympathetic is acetylcholine from the preganglionic, but norepinephrine from the postganglionic. Right? And then the receptor on our effector organ from the parasympathetic system is going to be a muscarinic cholinergic receptor, right? A muscarinic cholinergic receptor. So, something to note here on muscle cells, again, at our neuromuscular junction, so somatic cells, just to make a note here, will also release acetylcholine. Right? And it's going to bind to the muscle cell nicotinic cholinergic receptors. And don't get that confused, because it may seem like muscarinic should go with muscle, right? But it doesn't. Nicotinic cholinergic receptors are going to be on skeletal muscle, right? On smooth muscle or on glands, we're going to have, right, a muscarinic cholinergic receptor. Right? And then one other part of the story, because we have a gland that is specifically dedicated to sympathetic function. Right? And that's going to be our adrenaline gland. Right? And so inside we have the adrenal medulla. And so this just says adrenaline gland, but it's the adrenal medulla. So the inside layer. Right? And we've already talked about it's going to be made up of these chromaffin cells. And so let's highlight that really quick. Right? These chromaffin cells, which again are neural crest-derived cells. And then these chromaffin cells, so again, this preganglionic, we can think of it as preganglionic sympathetic neuron, is still going to release acetylcholine because it's preganglionic by nature. But instead of it binding a postganglionic neuron, that acetylcholine is going to bind these chromaffin cells. Those chromaffin cells, in turn, those will release norepinephrine and epinephrine into the bloodstream. And now we get this global response. Right, this global response, what you call an adrenaline rush. Right, so we get release of adrenaline into our system, and now it's free to affect any organ that it wants, right, that gets blood supply. All right, so that's the broad overview. So it looks like acetylcholine is the general rule for our neurotransmitter. Right? The only places that we see norepinephrine are going to be postganglionic sympathetic, right, and then also from the chromaffin cells, which are still kind of like our postsympathetic, right? Postganglionic sympathetic cells. All right, and again, we see our sympathetic going thoracic through lumbar, everything that they can affect. And then in our parasympathetic here from the brainstem and the sacral region and all the things that it can affect. Most of these through, look at that vagus nerve, right? And so how is it that we can get separate action, right, on the same organ? So if my body is in fight or flight mode, and we've all heard this, we vasodilate our peripheral muscles in sympathetic mode. So we'll say vasodilate muscles. But I don't need to be digesting food while I'm in sympathetic mode. So I'm going to divert blood from here to my muscles, which means I'm going to have to vasoconstrict here in my digestion tract. Right? But all of this is going to be sympathetic control. So how do I vasoconstrict and vasodilate? Well, this is where we have the difference in those alpha versus beta receptors. So on smooth muscle, right, or on our arterioles, those alpha receptors, so arterioles with alpha receptors will vasoconstrict whenever they bind epinephrine and norepinephrine. Right? Those beta receptors will vasodilate. So we can see, so where would we have beta receptors? Well, we'd probably have beta receptors, beta adrenergic receptors, in skeletal muscle because we want to, right, vasodilate in sympathetic mode. We'll have those alpha receptors here in our GI because we want to, right, vasoconstrict under sympathetic mode. So this is one of the ways that we can do different things in different organs with the same substance, right? These receptors will do different things. All right. Now let's get into, and this is kind of repeating the same story. We can see, we have norepinephrine, right? Still acetylcholine, right? Just kind of gives us an idea. And then we have our sympathetic chain here too. All right, parasympathetic, same idea. All right, brainstem, right, sacral, acetylcholine, all the way across. All right, so how do we get these out of the neuron? We'll talk a little bit more about this where we talk about action potential, right, and how we, release these synaptic vesicles. But it takes this propagation of action potential coming down, which eventually is going to let calcium in. Right? And then once we have calcium in here, these guys are free to release their content extracellularly. Right? Just kind of the quick story of how that happens. And then once they go out, they're going to bind to their receptor. Right? And then that's going to do whatever that receptor's action is. So one thing to note here is we have certain autoimmune diseases. One of them that I want to talk about really quick is called myasthenia gravis. So myasthenia gravis. So this is an autoimmune disease where this receptor, so imagine if this is acetylcholine, this would be a cholinergic receptor. Right? So this is an autoimmune disease where we actually make antibodies that will bind, right, our little Y-shaped antibody. Let's do a different color so it's not the same color as that receptor. Right? That Y-shaped antibody will actually bind the receptor. Right? And now this acetylcholine can't bind the cholinergic receptor. Right? So what do we do in that situation? Well, one of the things we do is this is competitive inhibition, right? So we try to get a lot more acetylcholine. And so in this case right here, we have this acetylcholine esterase, which breaks down the acetylcholine back into its constituent parts, which is going to be a choline and an acetate. Right? And then somewhere in here, we have another enzyme that's going to convert that back into acetylcholine. I think it's choline acetotransferase. Right? Because we can't reuptake acetylcholine back into the neuron. Right? We can only do choline and acetate. So one thing that we do in this case is we will inhibit this enzyme, the acetylcholine esterase, so that now we don't break this down. Instead, we have a bunch of this acetylcholine hanging out here. Right? And this helps improve those symptoms. So this is one of the ways that knowing what these neurotransmitters do and where they act is really important because it has clinical application. All right. So this one is just showing us how they can't act on the same organ at the same time, how they will block each other's action, because this is a guiding principle. You cannot have sympathetic and parasympathetic at the same time in the same organ. Right? We can have it going on in different places. One of the classic examples is during sex. Right? We have to have this feed and breed mode. So below the waist, we are in parasympathetic mode. But above the waist, you have increased heart rate, increased respiration rate. That's all sympathetic. So we can have it happening in different places of the body at the same time, but never on the same organ. All right, and then here we see what we just talked about. Right, beta is going to lead to vasodilation. Alpha, adrenergic receptors, whenever they're activated, will lead to contraction. All right, and this is how we divert blood. Right, so we can divert blood again from the gut going to the skeletal muscle. All right, and this gets us to an incredibly important part of homeostatic function. And this is what we're going to call autonomic reflexes. This is not to be confused with somatic reflexes, right? This is not the same as where you go to your doctor and they hit on your knee to see if your leg moves, right? That's a patellar tendon test, right? It's your patellar reflex. Right? That's a somatic reflex. It involves somatic nerve, skeletal muscle, right? Sensation. These are autonomic reflexes. These are reflexes that you are completely unaware of. And so one of the most important ones that we can talk about is going to be this baroreceptor reflex, right? Which is going to have to do with maintaining a proper blood pressure. And we've all experienced this. Maybe this morning, whenever you got out of bed. You jumped out of bed too fast, and what happened? Or you stood up from the couch too fast, and what happened? You get lightheaded, right? Your blood pressure drops because your blood's pooled in your legs, or it's pooled right into the lower part of your body because, gravity. Then you stand up, and now all of a sudden the blood can't get to your head because it's all kind of sitting in other parts of your body, and your blood pressure drops, and you feel like you're going to pass out. So how does your body respond to that? Well, it's going to increase your heart rate. And you've all had this, and pay attention next time you stand up too fast and you get lightheaded. Your heart rate will start to increase because it's going to increase the blood pressure. And we're going to talk about how we do that. So let's start with kind of a blank spot over here to the side. All right, and you're going to want to write this down in detail. All right, this is going to be the micturition reflex. We're not going to worry about that at the moment. I just need some space here. So this is the BRR. All right, you guys ready? This is one of the things that you'll really know, the BRR. So, like we said, it starts with low blood pressure. You stand up too fast, right? You're bleeding, you bleed out, right? This is how we go into hemorrhagic shock too. But whatever it is, your blood pressure decreases. You're dehydrated, whatever. Blood pressure decreases. Right, this is going to be sensed by baroreceptors. Baroreceptors, all one word. Right, so baro, right, same thing as barometric pressure or barometer. It senses pressure. So these are pressure receptors. So baroreceptors in two specific places. In the aortic arch, right, so coming right out of the top of your heart from your left ventricle is your aortic arch. And then also your carotid sinus, right, which is going to be where, remember, the common carotid, external, internal carotid, they split off. At this point right here is your carotid sinus. And coming out of your heart, so let's just imagine your heart, out of your left ventricle, coming from up here, your aorta, and it arches because it's going to go down like that. That's actually, and draw the common carotid coming off the aorta like that. And here in this aortic arch, we also have baroreceptors. So we're monitoring the blood pressure as soon as it comes out, it's a good place, and then as soon as it goes to your head. So from there, from the aortic arch, it's going to go up the afferent vagus nerve, or afferent cranial nerve 10. Right, from the carotid sinus, it's going to go up the afferent glossopharyngeal, or the afferent cranial nerve 9. Right, and both of these are going to go to the medulla. Sorry, it's getting a little bit messy here, but we'll keep the pathway, try to keep it relatively clear. So it goes up to the medulla. And then from the medulla, it's going to go back down that cranial nerve 10, or the vagus. But this time it's going to be the efferent branch, right, going away from the brain. So it goes down the efferent cranial nerve 10, and it turns it off. Right? Why does it turn it off? What does that mean? So remember we talked about the vagus nerve is parasympathetic control. So your vagus nerve keeps your heart rate at a nice, slow rate. Your heart actually sets its own tempo. Your heart doesn't get any stimulation to say beat. Right? Your heart, your cardiomyocytes beat on their own. It has its own electrical system. But whenever they beat on their own, they beat at 120 beats per minute or more. Right? And what this vagus is doing is it's coming in, and it tells your heart, it's going to connect here to the SA node, and it's telling your heart to slow down. So it's telling your heart to stay in that 60 to 90 range, right? Because we don't want it beating that fast all the time. Things hearts that beat that fast, like cats, right? They don't live 80 years, right? They live 20 years. So we want to keep our metabolic rate low. We want to keep the heart rate down. So the vagus nerve, right, gives parasympathetic system or signals to your SA node that tells your heart rate to calm down, keep it down. So wherever we want to increase the heart rate, right, we turn that signal off. Right? So the efferent cranial nerve 10, the efferent vagus, sends less signals. It's off. Right? And where does it go? It goes to the SA node of the heart. And that's going to, right, tell that heart rate to increase by default. So we're increasing heart rate, right? Because that's just what it does. And so we're going to write in by default. Right? And so what happens whenever we increase heart rate? The story doesn't stop there, because notice we didn't begin with decreased heart rate. So we have to we're trying to correct this. So how do we get to increase blood pressure? So wherever we increase the heart rate, right? Sorry, this is going off the page. But wherever we increase the heart rate, we increase cardiac output. Right? So we increase the amount of blood that comes out. And wherever we increase cardiac output, right, we then increase blood pressure. So the more blood we get out, right, the more pressure that we have within our arteries. And now we fix the problem. Right? And this is a reflex. So as soon as we get this blood pressure back up, right, we're no longer stimulating those baroreceptors. So then they kind of calm back down, and we do this off and on until we reach this place of homeostasis. And that's the baroreceptor reflex. Right, so let's just recap. So decreased blood pressure. It's sensed by baroreceptors in the aortic arch and the carotid sinus. Right, they'll go up our vagus and glossopharyngeal, right, our afferent, really important, afferent vagus and afferent glossopharyngeal, respectively, to the medulla. Right, and then once we're in the medulla, we send a signal, or really we send a lack of signal, back down the efferent vagus, telling the efferent vagus to turn off. Right, so that connects to the SA node of the heart, which will tell the heart rate to increase by default. Remember, no more parasympathetic signal, so the heart rate goes up by default. That's going to increase our cardiac output and then increase blood pressure. And that's how we get our cardiac output, our blood pressure, back up.